Thank you for coming, and it is really a pleasure. And I will try to tell you a story that very few people appreciated a while back, but I don't know why. So, cholesterol, we call it a Janus molecule. Janus is the two-faced god. It has a good, a light side and a dark side. And I will try to convince you that there is a bright and a dark side in development too. So, the first fact that you should remember, there is no life without cholesterol. If you have a mutation in a gene and there is absolutely no residual cholesterol, you are dead. There is no debate about that. The second is, if you have mutations in the genes that synthesize cholesterol, and you have inappropriate cholesterol synthesis, you will get a developmental disability, a complex intellectual and developmental disability. So, there are two pools of cholesterol. One is in the brain, the other is in the body. And those two systems do not communicate. They are basically separated by the blood-brain barrier. Now, the brain loves cholesterol and lipids. The heart and the blood vessels hate it. If we move on, why is it so critical in the brain? What does it do? Well, let's see, this is the pointer, here we go. It synthesizes precursors. It's essential for the myelin sheaths. It controls cell division, the membrane raft and receptor assembly. It is essential for the ER Golgi. It is essential for neuronal morphology and neurotransmitter release. All of those are cholesterol biosynthesis dependent processes. And your brain is only about 2% of your body weight, but it is 25% of the lipids. That's the most lipid-rich organ in the body. Does not cross the blood-brain barrier, so the brain synthesizes its own cholesterol. And it doesn't matter what you eat, how much cholesterol you bring in through diet, it does not matter for the brain. It starts during embryonic development. The brain cell starts at that point, synthesizes, and it peaks in the first postnatal weeks and remains throughout the life constant. Now, this is a very important point. Think about it as building a house, and you are building a roof. You need a lot of lumber and wood, right? But later on, once you build the house, your need is minimal for that wood. And that is very similar analogy to the developing brain. Because later on, cholesterol is a very stable molecule that hangs around about 10 years in your brain. The half-life of cholesterol is about 10 years in the brain. So you need initially an incredible amount, and later on you can get by with very little. So, different brain regions show different cholesterol and lipid content. And the studies have consistently shows that in later life, if you have a higher brain cholesterol level, you have a better cognitive performance in the elderly. So, developing neurons synthesize their own cholesterol, but who is synthesizing this? Which brain regions? So on. This would be your first enzyme in the cholesterol biosynthesis. This would be the last enzyme. And this would be in situ hybridization, basically labeling of the cells that produce cholesterol. And this region, this is a mouse brain, and as you can see, this region is very strongly synthesizing it, and that would be the hippocampus. Now, if you take out these neurons and astrocytes and separate them out, and you grow them, and you are looking at their cholesterol content, you will see how consistently they are increasing the neurons their own cholesterol biosynthesis. So they are themselves synthesizing. On the other hand, astrocytes seem to have a slightly lower level but very consistent synthesis, and there is a complex interplay between the glial cholesterol biosynthesis and the neuronal cholesterol biosynthesis. I told you that pathogenic variants, as they call them now, it has been called previously mutations, now the proper term is pathogenic variants, result in disease. So this is basically the post-squalene cholesterol synthesis pathways, and it is proceeding basically through two different branches, the synthesis. And if you have mutations in these enzymes along the way, you are getting different developmental disability syndromes, intellectual and developmental disability syndromes. This part is called the block pathway, and this is the Kandus-Russell pathway. And please focus on this last step. And this last step, if you have in this step insufficient cholesterol biosynthesis, then you get a developmental disability that is called Smith-Lemli-Opitz syndrome. And this is a very typical, and that's the most common developmental disability, and this gives you a very typical phenotype that we will go through. So, if you have two mutant, or most properly pathogenic variants of this DHCR7, the last enzyme, then you get Smith-Lemli-Opitz. One mutant copy, so you usually get the disease when you get two copies, one inherited from mom, one inherited from dad. On the other hand, if you have one mutant copy, not a big deal. It seems to be okay, right? And it is always assumed that it has no effect on a function and development. But these one mutant copy carriers have mildly elevated 7-DHC levels, the precursor of cholesterol in the brain. And these are very common in the human population. About 3% of the human population have these pathogenic variants, which are okay, we are assuming at least, right? So now if you have two pathogenic variants, then you get Smith-Lemli-Opitz syndrome. And this is a developmental disorder with about 1 in 10,000 live birth, small brain, seizures, altered morphology, shrinking corpus callosum, so a bunch of brain malformalities, and also body malformations, short stature, cleft palate, cataracts, strabismus, syndactyly when the fingers are together, or polydactyly when multiple fingers, heart defects, so a bunch of different dysmorphologies, which are basically related to the lack of cholesterol in different tissues. But the behaviors are very interesting, from learning disabilities to hyperactivity, aggression, self-injury, insomnia, ritualistic behaviors, and most importantly, they are about 75% of them are on the autism spectrum. So, again, this is 7-DHC, the precursor, the immediate precursor of cholesterol. This is cholesterol. Normally, there is a very small level of 7-DHC in the cells because it's very rapidly shuffled over by this DHCR7 enzyme into cholesterol. So this is a very quick conversion. So you have a lot of cholesterol and barely any 7-DHC. Now what happens in Smith-Lemli-Opitz syndrome? This enzyme is not working. You have a backlog, a logjam, and this precursor starts now to accumulate. So it's not only the lack of cholesterol, but these this precursor, this 7-DHC, is the most oxidizable lipid known to mankind. And it starts falling apart, or more precisely scientifically, auto-oxidizing, and it generates all kinds of oxysterols that are highly toxic for the cells. So you have a double whammy. One, you have a lack of cholesterol, and two, you have accumulation of toxic materials inside the cells. And so we can show this in a cell culture if we expose cells to this mixture of various toxic oxysterols. They are very quickly dying in the cell culture, and neurons, cortical neurons, are dying even faster than the glial cells, the astrocytes. And you can see already that the morphology of the cells, even in the culture, is completely different. So, we know that genetics is a key factor, but the question is, are there any medications that would interfere with this process of cholesterol biosynthesis, and what would be the outcome of such interference? And we did a screening a while back for basically about 1,500, no more, 3,500 at the end, different compounds. Pretty much all of the compounds that are used in human treatment, and asked the question, if we do a robotic screening on neuro-2A cells, will they inhibit this cholesterol biosynthesis? We didn't ask whether they are antipsychotics or anti-this or anti-that, or what purpose they are used. We went for everything. And basically, we analyzed for some of the precursors and cholesterol, but most importantly, this 7-DHC again. And what did we find? So at least some 30 compounds significantly increased these 7-DHC levels. That's the toxic compound, remember, for the cells. And these were very different kind of medications, including one of them was aripiprazole. And in 2015 in the USA was the biggest selling prescription drug. So this has some clinical relevance. And when we look at how the FDA used to classify both aripiprazole, haloperidol, trazodone as class C compounds that risk not ruled out, animal reproduction studies have shown adverse effect on the fetus. Well, hey, there is nothing in the human, right? Why do we care? No, they don't say that. Actually, they say we don't have enough data on humans, which is a very different thing, right? So they are still very commonly prescribed to pregnant women. So you have from acetate starts cholesterol biosynthesis. It goes through the two different branches. And then you have an elevation of 7-DHC if this DHCR7 is blocked. And it can be done by genetic inactivation that leads to loss, or it can be done by chemical inhibition, and these are some of the compounds that we found. And what happens is that this 7-DHC increases, 7-DHT, another precursor increases, desmosterol and cholesterol decrease. So, we looked at cariprazine and trazodone, and we were looking how does in the newborn pup, if you give it to a pregnant mouse, and you analyze now the progeny, right, when they are born, the pups at P0, what do you find? So if you treat with a vehicle, this is the 7-DHC level. This is with aripiprazole, this is with trazodone, this is with cariprazine, which is one of the strongest inhibitors. And you can see that this is a pretty significant increase from baseline, and there is a good correlation between 7-DHC and this most toxic oxysterol, DHCEO, that the more 7-DHC you have, the more toxic products are generated. And that was both true for cariprazine and trazodone. This is all published data. Now, the other question, this is Marta's coming from Marta's work in our laboratory in collaboration with Maria. And we asked the question, what happens if you have a polypharmacy? Polypharmacy is becoming a huge problem worldwide, and especially in women. Yet, drugs are always tested when they are approved in single medications. Another medication is actually a reason to exclude you from the study. Yet in real life scenario, you are very often giving 2, 3, 4 medications, and some of those medications are prescribed by different specialties. Some by a cardiologist and some by the psychiatrist. And they are not even thinking about it that those 2 medications might interact. So, what Marta did is basically looked at vehicle, aripiprazole, trazodone, and aripiprazole plus trazodone. If they were applied simultaneously, in this case, to the developing mouse brain and body. And what you are seeing is that, yes, the effect either summates or potentiates each other, so the effect on this sterol inhibition is getting even bigger if you are giving 2 medications at the same time. Now, this is where it becomes more interesting, even more interesting. If you have a certain genetic makeup, right, that 3% of the population that has one mutation, that is, we presume that it's not significant, and you get this drug, what does it happen? And the question is this, basically. Do medications and genetics interact? So you can imagine that during pregnancy, a mother is prescribed trazodone or aripiprazole or a combination of those, which elevates this 7-DHC. And then the mother carries this DHCR7 mutation, which also by itself a little bit elevates 7-DHC. And the baby has also a slightly impaired cholesterol biosynthesis. And when these 3 together combine, then you get a much stronger elevation of 7-DHC, and then that could disrupt development and potentially lead to disease. So the questions here were, do these heterozygous carriers here more vulnerable to medications, and is this most pronounced during development? And obviously, which medications are the most dangerous? So this was a human dermal fibroblast study, where we took fibroblasts from people who had 2 normal copies of the steroid biosynthesis gene, this DHCR7, and the parents of SLOS patients who had only 1 bad copy, who were considered totally normal. And you can see that those responded to the medications who had that 1 copy mutation, responded with a much stronger rise in 7-DHC levels and decreased cholesterol levels, both for aripiprazole and trazodone, showing the case that not equally everyone is equally vulnerable to the medications, to this side effect of the medications. And how does it really relate to the human disease, right? SLOS is a very severe developmental disability with all these issues, and this is the level in the SLOS patient fibroblasts. And if you give basically aripiprazole to those people, to those fibroblasts that carry one mutant copy, then you are getting somewhere almost around the level of what you see in Smith-Lemli-Opitz syndrome. So you are getting close to the toxicity of a grave developmental disability. And this is human biomaterial. But is this happening also during pregnancy in mice? So this is a little bit complicated. I will try to run through it. So you can get a pup who is a heterozygous, who has one of these mutant copies by two mechanisms, that they inherit it from the mother or they inherit it from the father. And this would be here, in this case, the maternal inheritance, and in this case would be the paternal inheritance. The idea is here that this mouse here is probably the worse off, because the mother has the mutation, the one copy, the pup has a mutation, and you give it medication. In this case, the maternal environment is intact. And we wanted to know, does the maternal environment also matter? So our hypothesis was that this group is the most vulnerable, where the mother is a heterozygote, the pup is a heterozygote, and they received aripiprazole and trazodone. And right away, we noticed something, that the aripiprazole-treated pregnant dams had 22 pups, and the untreated had 43 pups in our studies. So half of the time, we didn't even get a pregnancy. And then, as we predicted, this group had the highest elevation, basically, of 7-DHC, where the mother was a heterozygote, the pup was a heterozygote, and they received the aripiprazole. And we had pretty much the identical story with cariprazine, that the highest and the most affected group was mothers, pup, both have the mutation, and you give cariprazine. Now, this 7-DHC, that molecule, again, I told, is highly oxidizable. It falls apart to toxic part. The most toxic one is DHCEO, and the most common one. And we have a SLOS mouse model, and in SLOS mouse model, the DHCO level is this one. And as you can see, if we give cariprazine to a heterozygote mother with a heterozygote pup, you are getting basically the identical level of toxic compound. The other thing is to keep in mind that some of these medications hang around for a while after birth. Some of these are very long-lasting. One of them is cariprazine, and you can see that we stop the injections here. But even after some 21 days, postnatal 21 days, we could still find in the brain of the pup the medication. So they might still influence cholesterol biosynthesis even after. Fair criticism, always we get that. A mouse is not a human. Which I would love to come back with a question. Do you honestly think that if you disrupt a mouse brain, which has an identical cholesterol biosynthesis as a human brain, why would you believe that a more complex system as a human would be immune to this. But we have to look a little bit deeper. Guess what? When we looked more clearly, we found this paper that depicted that Smith-Lemli, they thought that the kids had all Smith-Lemli-Opitz syndrome based on their 7-DHC levels. And they looked for the mutations, and they didn't find anything. And then they went back and looked at the charts, and all of them were receiving either aripiprazole or trazodone. So that was one of the first papers that came out. The second was this one, more recently, that in the postmortem brains of patients who were receiving these medications, trazodone in this case, they had elevated 7-DHC levels. So it's basically we are seeing the same in the human brain. And these are our studies. And if you look, basically clozapine didn't elevate it, but haloperidol elevates this 7-DHC to cholesterol ratio, changes the 8-DHC. So the bottom line is that we are seeing in the blood of psychiatry patients also the same phenomena that it elevates 7-DHC. And aripiprazole and trazodone are the two probably biggest offenders. In this case, you can see what the other medications do to the 7-DHC cholesterol levels, and here what aripiprazole does in the human population. It's a serum psychiatry patient. The more cariprazine, basically plus metabolites, the higher this 7-DHC in the blood. Okay, so this was all adult brain. How about pregnancy? Obviously, we cannot analyze pregnant children brains, but we can analyze maternal blood. So we went to the Nebraska Biobank and we pulled some 1,300 samples, de-identified samples that we had blood from, and we analyzed for, analyzed for 7-DHC levels. And we have found first that mothers take it at pretty high rate, and pretty commonly these medications, and that 301 out of 1,300 women had elevated 7-DHC, and out of those 48 contained medications that we previously identified as DHCR7 inhibitors in the human pregnant women blood. The other interesting finding here was that if we looked at the whole population of women, this was the level of 7-DHC. Now, if they took one medication, it was already the elevated level, and if they took 2 or more medications, that level was even further elevated, so basically replicating our animal studies that the effects of these DHCR7 inhibitions are summative in the system. And then sometimes a gift falls in your lap. Unexpectedly, out of the blue, something that you don't even think about. And this new syndrome was discovered in 2023, in the fall of 2023, by Karen Grip and colleagues from Delaware. And the babies were born with short stature, microcephaly, facial features, cognitive abnormalities, cleft palate, club feet, small testicles, broad thumbs, and so on. Does that remind you of anything? It reminds you of Smith-Lemli-Opitz syndrome. The phenotypes of these patients were very much like Smith-Lemli-Opitz, and they were misdiagnosed again with Smith-Lemli-Opitz. And they went biochemically to look for this marker of Smith-Lemli-Opitz syndrome, the 7-DHC. And yeah, it was there. And they did the sequencing and nothing, absolutely nothing. And then they went back to the charts of the patients and asked what was common between these mothers, what did they take, and so on. And in the meanwhile, this 7-DHC cleared out from the blood of the babies. So it was clearly not a genetic mutation because that would have remained in it. And the babies all of these babies were born after pregnancy where the mother abused fentanyl. These were the pictures from those papers. This is how the kids look like. And this basically gave us a very interesting hypothesis that if you have a phenotypic similarity, so it looks similar, does it mean that the underlying mechanism, how it arises, is also related? And the answer is that maybe, right? We can think about it that this is the point where this loss mutation affects the biosynthesis. What if this fetal fentanyl syndrome arises also by inhibiting this exactly same step in the biochemical pathway, which would reduce desmosterol, cholesterol, and elevate 7-DHC? So, the hypothesis that came out of this was that fentanyl is a steroid biosynthesis inhibitor during embryonic development. And the second is that the steroid biosynthesis is stronger when it is combined with a single pathogenic variant of the gene. So this was the experimental design. This is also all published. So we took multiple systems, experimental systems. We took neuro-2A cells. We took developing astrocytes, developing neurons, and two kinds of human dermal fibroblasts, those who did not have mutation and those who had one copy of the Smith-Lemli mutation. And then we gave in a tissue culture fentanyl to these cells. And what we found that this whole pathway is completely disrupted in a very, very complex manner. So it did impede cholesterol biosynthesis, but not only at this last enzyme, but the whole cascade before it also. And we found in the fibroblasts that if you had those fibroblasts that had this DHCR7 mutation, much stronger reacted to fentanyl than those who did not. So, and interestingly, it was all about this toxic precursor of cholesterol rather than the cholesterol level itself. So now obviously the question arises, some babies develop fetal fentanyl syndrome, others do not. So how does this happen? Well, I think that the key is that those 3% who carry the mutation, those are the most vulnerable. So this is where genetics and clinical practice interact. So in a way, if you have that one mutation, and then you add in the baby genotype, maternal genotype, the dose of the fentanyl, the duration, the timing, the other possible comorbidities, other possible drugs, polypharmacy, all that converges and disrupts post-lanosterol biosynthesis to a different degree, which now forms oxysterols and become toxic, disrupts the fetal development, and results in fetal fentanyl syndrome. Now, if you don't have any of these, then it's probably there is a mild disruption in the post-lanosterol biosynthesis and normal the development resumes. So I think that this is what separates fetal fentanyl syndrome babies from the typically developing babies. But this brings up another interesting question. Do we believe only that it's fetal fentanyl syndrome? Does it do anything else? Based on your genetic makeup, based on your genotype or anything, and we don't know that. Do we know that if they will predispose your child to ADHD or anxiety or learning difficulties? We don't know that at the current time, but I would guess that it is very likely that it happens. So, in summary, no life without cholesterol. The sterol biosynthesis contributes precursors to hundreds of other homeostatic processes. Brain is the most cholesterol-rich organ. The brain synthesizes its own cholesterol. Most critically accumulates during embryonic development. And there are two mechanisms by the pathophysiology arises: the lack of cholesterol and the accumulation of the toxic precursors. Many currently approved medications do have a sterol biosynthesis inhibitory effect. We don't want that, but we don't test for it. We don't know about it. These are very diverse medications. Psychiatric, cardiac, metabolic, and other conditions, they are just all over the place as far as indication goes. Pregnant women very commonly take these medications during pregnancy. And those psychiatry patients and pregnant women who are taking these medications show elevated toxic cholesterol precursor levels. Another study showed that first trimester exposure to DHCR7 inhibitors resulted in outcomes similar to those of known teratogens. That is not our study. That came from a different laboratory. That is unrelated to us. Internal pharmaceutical companies raise concerns of their own based on the animal studies, but when you look at their own papers, there is a 40-page insert, and on page 27, with tiny, tiny letters, they will say, yeah, in pregnancy, maybe not ideal to take, right? Maternal and baby genotype matter. And keep in mind, cholesterol synthesis in mouse and human are identical. That's the same pathway. And we are not talking, actually, in all the vertebrates, you have the same cholesterol biosynthesis pathway. So why do we believe that cholesterol inhibition is bad for the developing mouse brain, but not in the developing human brain? And ultimately, medications and pregnancy will interact, but it will depend on many factors. I think that infections, chemicals, your whole environment where you live matters. The maternal comorbidities are an interesting question: diabetes, high blood pressure, autoimmune diseases. Then substance abuse, habits, nutritional status, poverty, the genetic makeup of the child and the mothers, and again, the polypharmacy, dose, duration of the medications, those all go into a very complex equation. And now, you can have no cholesterol disruption, which is not depicted here, or you have a developmental sterol biosynthesis disruption. And if you have a strong inhibition, then you get these dysmorphologies like microcephaly, cleft palate, club feet, syndactyly, small testicles, and so on. And if you have a moderate inhibition, I think you will get the behavioral dysfunctions. And the behavioral dysfunctions can be from autism to OCD to ADHD to learning difficulties. And I believe that you will hear some of our new data on that one soon that has been accepted for publications but is currently under embargo until further time. And again, I would be amiss if I wouldn't thank the wonderful, wonderful group of collaborators, both from multiple institutions. Certainly, Željka has been absolutely the driving force and the brain behind all these studies. with a great group at UNMC. Karen Grip, who was the one who discovered the fetal fentanyl syndrome. Maria and Marta has been amazing collaborators. Vanderbilt University were the chemists who were absolutely essential to develop the analytic methods that we can measure everything. And we came from there, and there have been some amazing lab members and collaborators there. And then the great collaboration with Debrecen University in Hungary with István Balog and Kati Kocok. And we really have special thanks to the individuals who agreed to donate their biomaterials for the study. And with that, I'm happy to take any questions that you might have. Thank you very much.